uterine body benign diseases are benign smooth muscle neoplasms that typically originate from the myometrium. They are often referred as uterine myomas, and they are also called fibroids, being found in approximately 40% of women overall, and are more common in nulliparous and obese women, and in those with family history or of African descent. Leiomyomas are round, rubbery tumors that, when bisected, display a whorled pattern. They possess a distinct autonomy from their surrounding myometrium. Because of a thin outer connective tissue layer. This clinically important cleavage line allows leiomyomas to be easily shielded from the uterus during surgery. Histologically, leiomyomas contain elongated, smooth muscle cells, aggregated in dense bundles. Mitotic activity, however, is rare and is a key point in differentiation from malignant leiomyosarcoma. This picture, as we see here, grossly myomas. This is the histopathological picture. This is the normal tissue and this is the fibroid. This is the normal tissue and this is the fibroid tissue. Myomas may change if a smooth muscle is replaced with various degenerative substances following necrosis. Leiomyomas have a lower arterial density compared with the surrounding normal myometrium. Moreover, their lack of vascular organization leaves some tumors vulnerable to hypoperfusion and ischemia. Acute pain may accompany degeneration. There are types of degeneration. Red degeneration, hemorrhage, and necrosis occur within the fibroid, typically presenting in the mid-second trimester of pregnancy with acute pain. Hyaline degeneration, asymptomatic softening and liquefaction of the fibroid. Cystic degeneration, also asymptomatic central necrosis, leaving cystic space at the center. Degenerative changes can initiate calcium deposition, leading to calcification. Rarely, malignant or sarcomatous degeneration can occur, but the incidence of this is 1 in every 350 cases or less. The suspicion is greatest in the cases or less. The suspicion is greatest in the postmenopausal period when there is a rapidly increasing size of the fibroid. Pathogenesis. Each leiomyoma is derived from a single progenitor myocyte. Thus, multiple tumors within the same uterus each show independent cytogenetic origin. Several unique defects involving chromosomes 6, 7, 12, and 14, and others correlate with the rate and direction of tumor growth. Following their genesis, uterine leiomyomas are estrogen and progesterone sensitive tumors. are estrogen and progesterone sensitive tumors. Consequently, they develop during the reproductive years. After menopause, leiomyomas generally shrink, and new tumor development is infrequent. The increased years of persistent estrogen production as early menarche and with an increased body mass index. Age. Myomas are rare in adolescents but increase with the age during the reproductive years. Race. African-American women compared with white, Asian, or Hispanic women. Leiomyoma classification. These tumors are classified based on their location and direction of growth. Subserosal leiomyomas originate from the myocyte adjacent to the uterine serosa, and their growth is directed outward. When these are attached only by a stalk to their progenitor myometrium, they are called pedunculated leiomyomas. Intramural leiomyomas are those with growth centered within the uterine walls. Submucous leiomyomas are proximate to the endometrium and grow toward and bulge into the endometrial cavity. See, this is the pedunculated fibroid. Subserosal fibroid, serosa, intramural fibroid within the wall, submucous fibroid protruding toward the endometrial cavity, pedunculated vaginal fibroid. Most fibroids are small and asymptomatic, but they can be associated with the following conditions: abnormal uterine bleeding, usually heavy menstrual bleeding and intermenstrual bleeding; reproductive failure. Subfertility may result from mechanical distortion or occlusion of the fallopian tubes, and an mechanical distortion or occlusion of the fallopian tubes, and an endometrial cavity grossly distorted by submucous fibroid may prevent implantation of fertilized ovum. Recurrent pregnancy loss. Bulk effect on adjacent structures in the pelvis. Pressure and pain is unusual, except in the special circumstances of acute red degeneration or torsion of a pedunculated fibroid. Bladder and bowel dysfunction. Abdominal distension. In late pregnancy, fibroid located in the cervix or lower uterine segment may cause an abnormal lie. After delivery, postpartum hemorrhage may occur due to insufficient uterine contraction. As we see, pressure and pain, bladder and bowel dysfunction, abdominal distension. Examination findings suggestive of uterine fibroid. General signs of anemia. Abdominal examination visible and or palpable abdominal mass arising from the pelvis. By manual examination, enlarged, firm, smooth, or irregular, non-tender uterus palpable. History and examination and investigations. A full blood count, severe anemia associated with heavy menstrual bleeding invariably indicates the presence of significant fibroids. bleeding invariably indicate the presence of significant fibroids. Transvaginal sonography, good for detecting and locating submucosal fibroids and small intramural fibroids. Transabdominal ultrasound scan, good for detecting larger intramural and subserosal fibroids and excluding hydronephrosis secondary to the pressure from fibroid obstructing the ureters. Saline effusion sonography, good for detecting and locating submucosal fibroid and endometrial polyps. Submucosal fibroid and endometrial polyps. MRI, good for describing the morphology and location of fibroids. Of fibroids. Conservative management is appropriate where asymptomatic fibroids are detected incidentally. Medical treatment. Number 1. Injectable gonadotrophin-releasing hormone GnRH agonist, which induce a menopausal state by shutting down ovarian estradiol production. GnRH treatment is not tolerated by all women because of severe menopausal symptoms. Number 2. Selective progesterone receptor modulator uricrystal acetate has been shown to be as effective as GnRH agonists in reducing fibroid volume. Moreover, when ovarian function returns, the fibroid regrow to their previous dimension. And alleviating heavy menstrual bleeding symptoms. Minimally invasive hysteroscope surgery can be used to cut away a submucous fibroid. Myometrium will be the preferred option where preservation of fertility is required, and this procedure can be performed through a laparotomy incision or laparoscopic. Number 3. Hysterectomy. Treatment by uterine artery embolization is a technique performed by interventional radiologists. It involves embolization of both uterine arteries under radiological guidance. Complications include fever, infection, fibroid expulsion, and potential ovarian failure. Now we will talk about endometrial polyps. Endometrial polyps are focal endometrial outgrowths containing a variable amount of glands, stroma, and blood vessels, which influence their macroscopic appearance. Symptoms may be asymptomatic, abnormal uterine bleeding, heavy menstrual bleeding, intermenstrual bleeding, postmenopausal bleeding, adversely impact on fertility. Risk factors: obesity, late menopause, the use of partial estrogen agonists as tamoxifen, and possibly the use of hormonal replacement therapy (HRT). Pathophysiology. Most polyps do not appear to be subject to the normal cellular mechanism that regulate the endometrium. Consequently, they are relatively insensitive to cyclical hormone changes, leading them to persist and cause unscheduled vaginal bleeding. Endometrial polyps contain hyperplastic foci in 10 to 25% of symptomatic cases, and 1% is frankly malignant. The risk of polyp harboring serious endometrial disease is increased after the menopause, and with the use of tamoxifen. Endometrial polyps may be pedunculated or scissored. of tamoxifen. Endometrial polyps may be pedunculated or scissored, single or multiple, and varying in size from 0.5 until 4 cm. This is the endometrial polyp, as you see. This picture taken by hysteroscope. Also a polyp. Diagnosis and treatment. Diagnosis by transvaginal sonography scan, saline infusion sonography, hysteroscopy. Polypectomy is a simple procedure that is performed in an outpatient with or without local anesthesia. Cervical stenosis. Cervical stenosis. Cervical stenosis refers to a pathological narrowing of the endocervical canal and is usually an iatrogenic phenomenon caused by a surgical event. As in treatment of pre-malignant disease of the cervix using a cone biopsy or loop diathermy can cause cervical stenosis, as can endometrial ablation affecting the os also. Is by surgical dilatation of the cervix under ultrasound or hysteroscopic guidance. Asherman syndrome. Irreversible damage of the single layer, thick basal endometrium. Does not allow normal regeneration of the endometrium. The endometrial cavity underneath of the endometrium. The endometrial cavity undergoes fibrosis, adhesion formation, termed as Asherman syndrome. The result is reduced or absent menstrual shedding and subfertility. You see, this is the band between the uterine wall called Asherman syndrome. Also, this is the bands. This is the bands, as you see. Also, this is severe case of Asherman, as you see, all bands and almost occluded the endometrial cavity. Factors. This usually occurs after following a pregnancy where there has been uterine infection endometritis, following over-vigorous curettage of the uterine cavity during surgical management of miscarriage, or following secondary postpartum hemorrhage while attempting to evacuate this retained product of conception using metal instruments or suction cannula. Of Asherman syndrome. Hysteroscopic surgical techniques are needed to manually break down the intrauterine adhesions, called adenolysis. However, the treatment can be difficult and risk further uterine trauma. Thank you for listening.